Hello, and welcome to the Clinical Liver Disease video series. CLD is an official digital learning publication of the AASLD. My name is Karim Osman. I'm a gastroenterology and hepatology fellow at the Leahy Clinic in Burlington, Massachusetts, and the author of the manuscript entitled The Clinician's Dilemma with Spontaneous Bacterial Empyema. Spontaneous bacterial empyema, which I'll be abbreviating as SBE moving forward, is a potentially fatal complication of hepatic hydrothorax in patients with decompensated cirrhosis. SBE is mainly diagnosed similar to spontaneous bacterial peritonitis by a pleural absolute neutrophil count greater than 250. However, unlike spontaneous bacterial peritonitis, SBE should be regarded as spectrum ranging from simple pleuritis to complicated SBE and empyema. We highlight that spectrum of SBE and how to diagnose and manage patients based on where they lie in that spectrum in Figure 4 of our manuscript. All patients with SBE will require antibiotics. Typically, we use a third-generation cephalosporin. After establishing a diagnosis of SBE using a neutrophil count, it's important to measure the pH, glucose, and LDH in the pleural fluid. A pH less than 7.2, glucose less than 40 milligrams per deciliter, or an LDH greater than 1,000 shifts the patient from simple SBE to complicated SBE. This is mainly based on ample pulmonary literature in the parapneumonic effusion. In patients with complicated SBE, it is important to obtain cross-sectional imaging or bedside ultrasound to assess for septations or loculations. If loculations are found, then source control in addition to antibiotics would be warranted. This can be in the form of a chest tube, intrapleural fibrinolytics, or even thoracic debridement. It's important to note that chest tubes are contraindicated in hepatic hydrothorax. However, they do have a role in complicated SBE, where it's mainly done to drain a loculated effusion for source control rather than continuous drainage of pleural fluid. And typically by this point, our infectious disease and pulmonary colleagues should be involved in the complex care of these patients. If during your diagnostic fluorescentesis, the pleural aspirate was pus, then this is empyema and you'll immediately typically need source control. That said, there are many questions about the management of SBE as there's very little literature on this topic. The role of albumin, repeat pleural fluid analysis after treatment, and secondary prophylaxis have not been adequately studied, but most guidelines recommend following the guidelines established for spontaneous bacterial peritonitis. On behalf of all of us on the CLD team, I hope you have found this commentary about the management of spontaneous bacterial empyema useful. For more information about spontaneous bacterial empyema, please visit us at www.cldlearning.com. Thank you again for watching.